Ready.
Jane.
We might give a couple more minutes. You want to?
Yeah, because that's only 3 of us right now.
Yeah, I don't think we're going to get a quorum.
No, right.
I'm going to make that bigger. Oh. We can make this full screen too. How do you do it?
It's yours.
I know.
Oh, okay.
Is that better?
That works.
Okay. But let's not hit leave. We can't lose you. Okay.
Not yet. At
Okay.
this stage.
I almost hit leave when I was messing around with that computer.
Lynn, can you hear me?
Yes.
Okay.
Can you hear Joe okay when he talks?
Yeah.
Okay.
I don't have something in.
Do you want then? We've got the. All right. I think we still don't have a quorum. Should we call to order anyway?
Just wait a couple minutes. It's at least 1 more minute.
Okay.
So we don't have John. We don't have.
Well, I want to, while we're waiting for a couple more people, I want to ask if folks would not mind signing in the chat if you can. And if you have, if you're affiliated with an agency, include that information too. That will help us take accurate minutes. It's been a nice feature of Zoom meetings.
Mm-hmm.
So much appreciated when you can do that. Joe and I are here in the Brookings Administrative Building because I think that's one or both of us are required per the emergency revisions to the Open Meetings Act.
It's just going to be the 3 of us.
So do you want to call to order? And
Just go ahead and call to order.
all right, you do it.
Okay, call to order. Start it up. Roll call, please.
Matt Hausman. Daphne Maurer. Molly McClay. Joe Omosagie.
Here.
Elaine Palencia. Jen Straub. Jane Sprandel.
Here.
John Paul Joachim. Okay, we got 3.
And can we go ahead with 3? Since
Yeah, you just can't approve the agenda. You just go into your
So here's the agenda.
presentations.
This is the agenda that you can't approve. But you could Joe can make comments because it's not a meeting. We can.
Yeah.
All right.
Yeah, we're not even talking about that. Citizen of public participation.
Oh, okay.
Is there anybody out there? Nobody here.
Maybe on the call.
Yeah, is anybody on the call that would like to have some input right now? It's limited to 5 minutes. Seems as if there's no one there, so we'll go ahead and move into comments. John's not here, so my comments are Narcan's going to be over the counter, and hopefully that saves some lives.
That is big news.
It is big news.
It looks like Brenda Eakins would like to give public
Oh,
input.
okay. Go ahead, Brenda.
You know, I kind of have a question. I don't know if you can answer, but I have been attending what's called Mars Turn. Have you guys been involved in any of that? It has to do with the Mars is it has to do with people in jail getting what they need in the jails if they're addicted to opiates. And I don't think Champaign County's involved in that yet. From what I've seen, I don't, but similar to what you're saying now, Narcan's going to be, they're trying to get that available in the jails. So that's, when I know a little more about it, I've been through 2 of them. I'll let y'all. Okay.
Yeah,
Thank
I've
you.
heard of it. So, but thanks for bringing it up.
So
So we just
if
move
you,
it.
so we have the presenters here, Gail Rainey and Shelby Moreland from Rosecrans. Do you want to run the slides or do you want me to do it?
I can do it, Lynn. That's fine. Just give me just a second to get it pulled up.
Thank you so much. Looking forward to this presentation.
Oh, if I can get Zoom to cooperate with me. It's covering up all my options.
I'm going to learn how to use PowerPoint by watching you.
Oh, good luck. I didn't. Initially, Dave Keller Hall is our clinical services director, and Shelby, we're going to do the presentation. Dave is out unexpectedly tonight, so I will do my best to help Shelby with it. Shelby is the supervisor for our community-based services, and she directly supervises the crisis co-response team that's funded by CCMHB. So we were asked tonight to do our mid-year presentation on the CCMHB funded crisis co-response team. So we'll go over the program overview, and this is the first year that we've been doing this grant and this program. So we'll talk a little bit about the implementation and also about the accomplishments and things we've learned as we've been going through year 1. And then also the CCMHB staff asked us to speak a little bit about our other crisis related services. So we will also talk about that. Shelby's going to go ahead and take you through the CCMHB funded crisis co-response team information.
Thank you. So to start off, our crisis co-responder team is in partnership with the Village of Rantoul Police Department and the Champaign Sheriff Office here. Both are funded by the CCMHB. Within that is dedicated, specially trained staff in each jurisdiction, and the model is used is dependent upon each department's resources. So the goals of CCRT are to decrease the dependence on 911 in the criminal justice system. Our approach that we have designed the program with is once we receive the referral from a CIT report, we complete follow-up contact. Within that follow-up is providing case management services to link individuals with necessary resources and services. The other goals are to reduce the 911 calls, avoid future crisis situations, and gain stability within the community. Our other goal is to strengthen community wellness, and this is by providing education to reduce the stigma associated with mental illness. So with implementing our CCRT program within these 2 departments, we're addressing staffing. So both incumbents from CCRPC decided not to continue with the program. So this required some time in inquiring the appropriate recruitment for the best fit for both of these programs. And the development process within the law enforcement agencies who are also facing staffing issues. And then also building relationships and building the caseload with law enforcement and the public. So for our accomplishments for Q1 and 2, we had 42 meetings held with community and stakeholders. 73 contacts to engage potential clients. 5 of these were unduplicated individuals where the crisis was resolved and no further action was needed. And 26 were unduplicated individuals engaged in care coordination and or monitoring to support them until accepted into services and or until their needs were being met. And then to share a mission moment in order to kind of put these statistics into to come to life. I would like to share a client story. So we have had a female client in the Champaign County Sheriff's Department jurisdiction. And this individual had a significantly high number of interactions with the Sheriff's Department. This individual was having 4 to 6 calls for service for a behavioral health crisis a week. Since CCRT intervention, this client has had a significant decrease in call of services since that time frame. In February, this client had 23 days where she did not have a call for service, which was very significant for this individual. Since February, she has had 2 calls for service, but this is still a very significant decrease since CCRT has started at the County Sheriff's Department. And previous to CCRT involvement, this individual was not willing to participate in any outpatient stabilization programs. And so since our involvement and since February specifically, she has now agreed to engage in treatment. And she is currently at Rosecrans for counseling services, as well as our community support program, which provides case management services to her, as well as continuing her outpatient psychiatry at Carl.
Thanks, Shelby. This is all part of our larger continuum of services for crisis. One of the ways, I always put this slide in to help people. One of the ways, if you are in crisis or know someone in crisis, is to use the 988 number. And we, even with the implementation this year of 988, we have kept our local crisis line active because we know a lot of people in Champaign County know that number and they do still use it. And so we also, as part of our staffing, we staff that crisis line, the local crisis line. The 988 calls do come directly to us after they speak with the 988 person. And if it's appropriate for our team, they route those calls to us. Also, for any of our mental health services, we have walk-in appointments or sessions available Monday through Friday for a mental health assessment at our 801 North Walnut Champaign location. So all of these services work together, as Shelby talked about with their mission moment, helping engage the person so that they do follow through and get further treatment is really the big thrust of the CCRT program, even though there's a lot that goes into getting that person engaged. But that's the whole point of the CCRT. We look for those outcomes. So our other crisis related services, we have a living room, a mobile crisis response team, and also a crisis respite center, or also known as crisis residential center. The living room is currently located at our 801 North Walnut location. There's a photo on the slide. It's created to look a lot like a regular living room and in a safe, comfortable space. It's non-clinical, so there's not a clinician in the room. There are peers in the room, and the peers are specially trained to try to help the people that use the living room connect to resources and services. If they need mental health crisis services, then a member of our crisis team will come and meet with them as well. But the whole point of the living room really is to decrease any unnecessary hospitalizations. A person can come and use the living room if they feel like they're close to going into crisis. They can come to the living room prior to the crisis. We also have people who come and use the living room after a crisis because they just need a place that's calming and quiet when they go back into their environment. fun fact too, because of the location of the living room, we have people that just go back there because it is a calm space. We'll have clients that come in for other services and will go back to the living room to decompress sometimes, but also to wait in between appointments because it's a calming space. And sometimes being other places within our building, like in the lobby where it's kind of busy, can actually increase someone's anxiety. So some of the people actually enjoy waiting in the living room instead. It's also a place where they get to interact not just with our trained peers, but with other people as well. And so it helps them build social networks, and is, as we know, during the pandemic, there's been a increase in the cycle of isolation. And so it's also helped with that. There's a place where people can go to feel safe. We do have a mobile crisis response team. It's staffed 24/7, 365 days of the year. And this staff not only help answer the crisis line and receive the referrals from 988, but they will go out into the community and or meet the people at the local hospital when there is a crisis situation. All ages are accepted. Doesn't matter who the pay source is. We do everything with the person depending on what the situation calls for. We do a crisis screening and assessment, disposition. Sometimes it's simply linking people to other services. It's not always someone who needs hospitalization or someone who needs intensive services. So it really depends on the person's situation, but the mobile crisis team is responsible for all of those pieces. And then we do have follow-up services after a person is seen by the crisis team. We do have some crisis psychiatry appointments available as well, if the person is engaged with our mobile crisis team. We talked about follow-up a little bit. CCRT has some follow-up pieces, but so does there are a couple of other pieces that come new to us, is a Pathways to Success program that is totally run through the state of Illinois. And the youth are actually assigned to us by the state of Illinois. It follows a person who has either had a crisis situation or who has had a mental health assessment, and it's flagged, if you want to say it that way, at the state as someone who needs more care coordination and support services. So there's a whole process on the state side of things, but then once we get the referral, we're responsible for helping with the care coordination and support services. And that literally just started this calendar year. So we're in the very beginning of that and building the caseload as we go. The family support program is known as FSP. That's also available for youth, and there's is also a piece of the puzzle that works with Pathways to Success. And that's a case management program where we help connect the client to services and or the family to services, not necessarily just within Rosecrans, but to other resources and services in the community. Another piece of the puzzle is if a person is either stepping down from the hospital setting from crisis, or maybe they don't have a need for something as intensive as hospitalization, but they do need a safe 24-hour place to be for crisis stabilization. We have a 10-bed unit for adults, and it's located at our Moreland site. It's a completely voluntary program, so there are no involuntary admissions for this program. It averages around a 14-day stay. And it also serves as a entry point sometimes for other residential services. So while the client's in our crisis residential center, it's also known by others as our crisis respite center. While the person's with us, if we or the client notice that there's a need for some of our other types of residential programming, for example, substance use disorder treatment residential, it's a seamless referral to those services because they're right there. They're actually all in the same building, and it makes it really nice to be able to help the person in the moment and being able to transfer depending on which unit or which services are the most appropriate at that time. And I'm not Dave, but my email is grainey@rosecrans.org, and Shelby's email is on here as well. If you have further questions after we're done, we're more than happy to help either try to connect you to resources or answer your questions as well.
Presentation.
There you go.
Thank you for the presentation. Does anybody have any questions or comments at this point? I know I have this one question or comment. Anybody can jump in right now.
I'll go ahead, Joe. So looking at your stats for the first couple of quarters, looks good. I'm kind of curious if you have any comparisons about what kind of contacts the sheriff's office and Rantoul were seeing, especially repeats, that people that weren't getting services and such as that. If you have any kind of comparison there.
We do have some stats, but Shelby and I would have to compile them for you, Matt. We can get them to Lynn though to send out to the board. That would be fine.
So that was that was kind of the vein I was thinking about for the follow-up programs for the Pathway to Success. Well, do you have any numbers that you've had for this year at all?
Oh, so it literally just started in February. And so at this point, the caseload is 13. The state is the state is actually in charge of this caseload as far as making the assignments to us. And so they purposefully have started, not just us as a provider, but all the providers within the state. They've started us very slowly. First of all, to make sure their processes on their end are working well, but also to make sure that our internal processes are serving the needs of the clients as well. We do anticipate that we will continue to grow this caseload. They've already told us that we will continue to grow this caseload. The Pathways program is somewhat unique as well, where there are peers involved in Pathways follow-up. And so it not only has the clinical component and the case management component, but also the peer component. And so we're looking forward. It's actually too early, Joe, to have any like outcomes data on that program, but we're really looking forward to seeing how well it's going to work and to try to help connect the youth and their families to some much needed resources.
I was also just thinking, where are these? Are these for lack of a better, indigenous youth to this community, and where were they and where they're coming from?
So we have been assigned by the state to a 9-county area. I did not pull before tonight's presentation the number that are only in Champaign County. Again, that's all handled through the state. And we're anticipating, so the process at the state is they review the IMCAN's assessment, see if it meets the eligibility for the program, first of all. Then after finding out if the person is eligible, the family actually receives a notification that they're eligible, and the family has to opt in to the program. And so if the family chooses to opt in, then we get the notification that they've opted in. So there's a whole process before it even gets to us.
Okay. So 9-county, and this Rosecrans, or is it Rosecrans around the states?
Both. So the Central Illinois Rosecrans provides for 9 counties. In Northern Illinois, we have even more counties, and we have a Rosecrans in the Kankakee area as well. And so they're covering the northern part of Central Illinois, if you want to call it that.
Okay,
and these are all separate teams, if that helps any too.
Okay. Good.
Should I read it?
Yeah, please.
Jessica McCann has a question. I don't know if, Jessica, if you want to ask it or you want to just read it from the chat, either way is fine. It's a good question.
Mhm.
Sure. Sorry, I need to get myself off of mute. Yes, I was just curious, Gail or Shelby, the peers that are part of the living room program or the FSP program, are these previous clients or how do they become involved as peers?
They can be. They are actually employees of Rosecrans, though, so they go through the employee process. We post a position on, just like we do any of our other positions, but the requirement, one of the requirements for those positions are they have to be a person with lived experience and have to feel comfortable saying that they are a person with lived experience. That's one of the things that makes them eligible for that position. So yes, they can be previous clients, but we have peers right now that have come to us from all over that we've never had previous interactions with, frankly, until they applied for the position.
Sure, thank you. That's really great.
Gail, I was curious about something. Is it okay?
Yeah, go
Can I jump
ahead.
in?
Yeah.
Just like how similar is the approach that used through the mental health board funded CCRT program to the program that serves Champaign and Urbana? Are those real similar? Is it the same staff? Anyway.
So should I say this? Right now the city of Urbana is the other CCRT team. They have a dedicated officer and a dedicated Rosecrans staff member. The difference between, one of the differences between the Urbana Police Department and how that operates is a little bit different than the Rantoul and the Champaign County Sheriff's Department. They don't necessarily, the other two that the CCMHB funds, they don't have the staff resources to be able to have a dedicated officer. And so because of limitations on staff resources, also Sheriff's Department brings a whole different realm to this because of the geographic layout and how they use their officers. So that literally each one of the different departments operates just slightly differently. But the fun part of it is if they want us to go out with them in the moment, we will, if they determine it's appropriate. And then also they will also refer people to us after they've had an interaction with someone, or like Shelby talked about, the Mission Moment client, that person was well known, frankly, to the department already. And so in those types of situations, they've developed a relationship with the person, but also our team develops a relationship with the person. And it really is, crisis co-response models vary greatly across the nation. And we have tried really hard to accommodate and adjust to whatever the department's needs are and to try to make it work for everyone, because the whole intent is to try to get that person to feel comfortable enough to engage in services and or to connect them to whatever resources they need. And so it takes some of that social work, if you want to say it that way, those types of duties off of the officers. But it really is a team. I can let Shelby speak a little bit more to how her team interacts actually with the officers, because that's like a super important part. And as we develop the relationships, that actually, Matt was asking about the stats early on. That was a big part of Q1, was just getting people hired in, getting them trained up, and getting those relationships and internal processes developed. So Shelby, you can speak a little bit more to exactly like what that looks like on a day-to-day basis for your team.
Yeah. So initially when we developed the crisis co-responder team in the original partnership, was creating it as to be a follow-up model, which really, when we gained partnership with the other two departments, had seen that this had really worked as building that relationship with our community and building our relationships with our department. Because it's really important for us to know how to work with these officers as well before implementing going on live calls and all those other factors, is building that same relationship that we're building rapport with our clients on a quickly basis. We're also building those relationships with our officers to have that trusting relationship too. So we have found that the follow-up model works really well in all three of the departments, ensuring that after a crisis, these individuals are getting at least trying to make at least 3 contacts. Sorry, I almost said one. At least 3 contacts of engaging with them. But then we've also have found, as we're developing this program, how significant and important it is for us to participate in the active call search service too. Because if that individual is in crisis and say I'm the clinician that's responding with the officer, if they remember me from that first experience when they're really at that crisis and that low, that trust is already there when I come back to do the follow-up, and then they see that's a consistent person in my life that wants to get me linked with services. And it also helps with that follow-up, because sometimes if we are solely depending on just the follow-up model, we have a significant high level of homeless in our community. And so it's hard for us to find that individual, and especially if it's a homeless person that I've never had contact with before, trying to identify, is this the homeless person I'm looking for? So if I've already had that contact when they're in that crisis, then it's a built relationship too, as well. So it's ever changing, and kind of, it's just like social work and police, it's always changing. And so we're adapting and molding as things come up, and finding what best serves our community.
Isn't Obeta kind of unique that they have, I think they have an MSW as an officer, is that in that? And so makes it kind of a unique arrangement already to work with.
Yeah, it's actually a fun fact. So Officer Bennett and I, we actually went to grad school together. So we both obtained our MSWs in the same program, same year graduating. So it was really fun to create the original program with her, which significantly helped build that credibility in the police department and in that community to start this program. So it's the little fun fact you guys get.
And I knew Officer Bennett as an undergrad, so I was one of her instructors.
Small down. Leon Bryson added into the chat that the next CIT steering committee is next week, April 5th, here in the Shields room. I'll be there. I'm so excited. It's been a long time since I could attend. And is that meeting open?
CIT?
Is the CIT steering committee meeting open to visitors, such as guests to this meeting? I'm not sure. It's a good group.
I believe so.
It's always a great discussion anyway.
Yeah. And I mean, for the community at large, if you have a chance to be CIT trained, I think it's a really good idea. So that, I mean, I received a CIT training about 10 years ago. So
really?
Yeah. Before I was on the board.
Cool.
Any questions or any other questions or comments?
Hi, Gail and Shelby. I just, you mentioned serving homeless individuals. So first, let me thank you, of course, for what you're doing. We've had a lot of success with the living room, especially. That's been kind of a lifeline for us when people have been escalated at different times, and they don't want to make an appointment with anybody and they need help right then. And so the living room has helped us kind of link people. We can kind of take them to that space, and they can see someone rather quickly. And So that's been great. And I think we've worked a lot with the CRC. That's been also a great resource for us. We've had homeless individuals that have been staying with us. They've had an opportunity to go there, get stable. And a lot of times they do return to the shelter, but they come back far more stable than when they left us. So that's fantastic. Can you talk a little bit more though about kind of the crisis response team? I know for me, like in previous jobs I was in, a lot of times we could get people to the hospital, for example, and that seemed to have one kind of route for assessing crisis. But a lot of times, like you mentioned, working with the homeless community, they're not necessarily going to want to, you know, either get on the ambulance or have someone take them to the hospital. So can you talk a little bit more about that process? Like when somebody's in the community, what does that look like?
So it comes to us through a telephone call, and we try to triage over the phone if possible, which actually sometimes happens. And 988 similarly acts as a phone triage type of system as well, where the statistics show that over 80% of calls to 988 and also to our own crisis line, over 80% of the calls nationwide can actually be handled over the phone. And it's more a person who just wants somebody to talk to. They're in desperate need of some kind of a resource, or they feel like they're not able to get their needs met. And so they're calling just to talk to someone. So if you take that piece of it, 80% of it out of there, it actually narrows it down quite a bit. And so if the person is truly, if the person is screened as being at a crisis level, then our clinicians, oftentimes the safest way, Melissa, is for them to go to the hospital, depending on, and so our clinician over the phone will try very hard to determine what's the best route here for this person. Oftentimes we'll know the person, frankly, because of previous interactions with them. And so a lot of this is done over the phone to determine what's going to be the next best step. And sometimes we will go out to the location. Sometimes if we've determined over the phone, this is imminent, then we will get authorities involved, because it really honestly is the safest way to help the person. There are a lot of legal restrictions on what we can and can't do that actually EMS has more things at their disposal to try to help the person in the moment. And so there's a whole triage telephone decision-making tree. And it really depends on the individual situation. So that's what Shelby was saying earlier too. Like literally each situation is different, and we try to accommodate and help the person the best way possible. And so it does depend on what's happening with the person in the moment.
I also just wanted to add that in addition, it's not only individuals who are experiencing a behavioral health crisis that can contact the crisis line or 988, any individual could. So Melissa, if you ever have any staff member that are witnessing someone experiencing a crisis, they're able to utilize either resource and kind of help triage the situation with you guys as well. So determining, does this person what advisement we would if it would be safer atmosphere for them to go to the emergency department for the evaluation, if we had someone on staff to be able to do the assessment at our Walnut location, or kind of help you triage from there as well.
Thank you so much. I appreciate that.
Thank you. Are there any other questions or comments? Well, if not, we'll go to any agency input about anything else.
I thought maybe we were frozen for a second.
We're not frozen. Board announcements. Well, it looks like if there are no board announcements, I'll move to adjourn. All in favor? Okay, so everybody just click.
Matt says yes. I guess
Okay.
that's it.
See ya.
Thanks,
Thank-
everyone.
We'll see you
Yes, thank you.
soon. Thank you.
Bye-bye.